Good morning, everyone, and welcome to the Epilepsy Expo. And guess what? It's official. Today is November 1st, and happy Epilepsy Awareness Month. And you're here celebrating. And we're celebrating you. So you're in the right spot for who is an epilepsy surgery candidate. We have a dynamic duo for you. Orange County's finest from CHOC, Pediatric Epilepsy Center, which is level 4. We have Dr. Phillips, who's the director of the CHOC Epilepsy Center, and we have Dr. Olaya, who's the director of surgery. And we work so closely with them, and they take such wonderful care of our families and our children. I might get emotional, so I'm just going to hand it off to them and soak up all that they have to tell you, and you will learn so much, and you'll be empowered to make those necessary decisions for your loved one. So, doctors, take it away.
Thank you. Hello, everyone. Can you hear us okay? So before we start, I just wanted to say thank you, express gratitude. I'm so thankful that we get to be here in person again. I will never take for granted being in person again after the last couple of years. And also express excitement for the same reason, kind of all together working towards the same goal. I know Dr. Olaya shares the same sentiment. We will get started. Do you want to start with disclosure?
Sure, yeah. So again, thank you, Janet, for the warm introduction. As Dr. Phillips mentioned, we're very excited to be here. Today we're going to talk about who a surgical candidate is. When we're deciding if someone is a surgical candidate, it's not just, it's a team approach. There's lots of people that go into making that decision. And so I think that's why it's great that we're being able to present this as a team, because that's truly how this works. In terms of our disclosures, we're part of the RESPONSE trial, which is looking at the safety and efficacy for RNS device in pediatric patients, and we're also part of the Lantern registry, looking at the use of laser ablation for some of our patients. So we'll discuss that a little bit during the talk today.
So we have some tight objectives in our 8-hour lecture today. Kidding. We could take 8 hours to talk about it, but we're not going to. So we are going to highlight how attitudes regarding epilepsy surgery have changed over time, because they've changed a lot over the last 100 plus years. We're going to discuss curative versus palliative surgical approaches, what that means, what are the pros and cons of each, and who benefits. We're going to define drug-resistant epilepsy, because that's important. That is sort of our 0 point into whether or not we're considering surgery. We are going to do some light audience participation today, just hands, where we're going to work through just a couple of less than straightforward surgical cases together and see what we come up with. And then ultimately we are going to attempt to answer the question, who is a surgical candidate? So a moment about that evolution piece. The International League Against Epilepsy has been around for over 110 years now. Pete Engel, Dr. Engel, who is one of my mentors at UCLA, wrote this a few years ago, celebrating the 110th anniversary of the International League. And even when they met in 1909, epilepsy surgery was already a thing. But at that point was considered sort of something that we do absolutely last resort. And I think, unfortunately, that kind of still pervades culture sometimes. Right? We think about epilepsy surgery as something so intense and so invasive that it could be something of last resort. We hope to convince you otherwise today. So Dr. Engel noted that advances continue, introduction of laser ablation, which we'll talk about today, palliative neuromodulation. All of the techniques that we use routinely now have opened up the group of patients who may benefit from epilepsy surgery tremendously. There have been 3 giant prospective randomized trials showing that epilepsy surgery is safe and effective, so we have definitive evidence that that is the case. Yet, less than 1% of potentially eligible patients are referred for epilepsy surgery. So there's a huge gap in who may benefit and who gets to benefit. And so I love this line. The major challenges in realizing the full potential of epilepsy surgery, not as much continued improvement of the treatment itself, although it will continue to get more precise, it will continue to get less invasive, but rather addressing the treatment gap that is preventing appropriate patients from being referred to a level 4 epilepsy center. This is a quick picture showing that in 1930, no one was doing any research on epilepsy surgery. And in 2016, they're doing a lot of research. These are a number of papers per year on PubMed, which is where we go to read about all of the trials. And then just a little guy down here, starting in 2017, still continuing to today. Lots of misconceptions about epilepsy surgery, though, so a few of them. You got to try a ton of medications first. Not true. We know that we are drug resistant after 2 appropriately chosen medications at appropriate doses. Multiple or diffuse lesions on MRI contraindicate surgery? Not necessarily. There might be, an alpha lesion that's doing the most of the work that we can target, or we have other approaches that can target multiple lesions. Bilateral, both sides. EEG spikes contraindicate surgery? Again, not necessarily. We have techniques that are focused on patients like that. Surgery is not possible if eloquent cortex is involved. So if my seizure onset zone is near language or near motor, I can't do surgery. And that is not true either, and we will talk about why that may be the case. If there is existing memory deficit, surgery will worsen it. In pediatrics at least, and I think in the adult literature as well, but I can speak certainty pediatrics, we often see either cognition, including memory, either stabilize or actually sometimes get better after surgery. Chronic psychosis contraindicates surgery. As you can imagine, epilepsy is, as a chronic disease, has a potential mental health burden. Many of our patients living with epilepsy are also living with mental health challenges. We can do both. We can walk and chew gum at the same time, so it is not necessarily a contraindication to surgery. We just have to be aware of it. That's why we do neuropsych testing. We have a whole team of mental health providers. IQ less than 70 contraindicates surgery. Far from it. I think we've seen with many of our patients who have intellectual disability that, again, surgery can be very impactful, not only with seizure count, but also in multiple domains, including cognition. So this is just an article about Dr. Engel from 2012. I like it because of a quote that you can't see. I can barely see it. Patients who are referred to epilepsy surgery finally are referred on average after 22 years. It is way too long. We do better in pediatrics by definition because our patients are not 22 years old. But it's still too long. It can take years still for a referral. So when we talk about surgery, when we think about surgery, we're thinking about curative surgery, where we're actually, there's a lesion, it's making epilepsy, we remove it, we cure the epilepsy. There are many patients like that, and many of those patients have not yet been referred. But in pediatrics especially, we're also talking about palliative. Now, palliative has a negative connotation. We think palliative, we think end of life, and that does not mean that, especially in pediatrics. Palliative means helping without necessarily curing. And so the idea is epilepsy is not just seizures, and those living with epilepsy know it, right? It impacts my cognition, it impacts what I can and can't do, it impacts my social network. So if I can do anything that can make any of those domains better, even if I'm not totally wiping out seizures, it may be worth doing. That's the conversation between the team and the patient, but that's what we mean by palliative. Even though we're not up here at 100% on seizure control, we're still making a potential impact with these palliative techniques. So classically, we've defined success by either the Engel criteria, again, that's Pete Engel from UCLA, where we talk about class 1, 2, 3, 4, seizure-free, rare seizures, worthwhile improvement or no improvement. Or we talk the ILAE, International League Against Epilepsy criteria. Both of these sets, very important for clinical work and research, but they only talk about seizures, right? So this paper was really cool, redefining success in epilepsy surgery, the importance of relative seizure reduction in patient-reported quality of life. So again, we can make meaningful reduction in seizure frequency. We can attack things like cognition and IQ points. We can attack things like being able to get out and do more in life, and be very impactful in ways that aren't well measured right now, but meaningful to our patients. And I think, Dr. Olaya, we both have lots of patients who fall in this category.
Yeah, we have countless patients. We were actually, as we were putting this talk together, we were just thinking about lots of patients that we've taken care of over the years. And one patient that I just recently saw a few weeks ago had a procedure, corpus callosotomy, which we'll talk about a little bit, to help with drop attacks. And this particular patient, was basically homebound. The family was always worried about taking her out because she could fall and hurt herself anywhere. And we did this procedure, and then since then, she was able to go to her first birthday party, which was so meaningful to mom and to her. And so it's things like that you can't measure on these scales that obviously make a tremendous impact on the patient and on the family, and we see it on a regular basis. So I think we always try to keep that in mind when we're thinking about who potentially is a good surgical candidate.
The other thing about pediatrics that is so critical is that we have these little pockets of irreplaceable developmental time. And so if I can significantly reduce seizures even during, let's say, ages 2 to 4. Ages 2 to 4 is a lot of development going on. So even if we don't end up totally seizure-free, I may be better off developmentally because I was able to participate in early school and interactions with my siblings in ways that I couldn't if I was having seizures every day. This is one of those slides where I'm like, you can read the slide, and I'm not going to explain the whole thing, but then I realized you can't read the slide, so I'm going to. Basically just demonstrating that over time, we have expanded the definition of who's a surgical candidate from kind of historically drug-resistant focal epilepsy impacting quality of life to now from the International League a whole list of conditions that may be surgical candidates. And I think this is from 2006, an outdated list. So when you do your internet research, you will come across all sorts of very good websites actually to describe who a candidate is. They all have similar flavors. A lot of them start with seizures that start in one area of the brain, and we'll cycle through a few of these. That is a critical group of surgery patients, not the only one. And so I think as we go through this kind of process, just to recognize that, yes, if I have, right temporal, mesial temporal sclerosis, we're going to do surgery and that patient's going to be likely cured from their epilepsy. It's a fantastic outcome, but we can be impactful in other areas as well. So here's one example, another example. This is from UT Southwestern. This is from epilepsy.com. I like this. Certain patients with uncontrolled generalized epilepsy who have drop attacks and tonic seizures may benefit from surgery, so acknowledging that there's another potential group. This is from Cleveland Clinic, kind of the same thing, I think towards about, in general, seizures are frequent, severe, and debilitating. That's enough for me to say, hey, we should at least look, kind of thing. We should have certainty around what drug-resistant epilepsy is, and there's a ton of people who got together and had a giant conference and decided what this meant. And it means drug-resistant epilepsy may be defined as a failure of adequate trials of two tolerated and appropriately chosen and used anti-seizure medication schedules, whether monotherapies or a combination, to achieve sustained seizure freedom. We need at least 2 medications that make sense for your epilepsy at appropriate doses for appropriate amounts of times, either together or separately. When those don't work, we are drug resistant. Drug resistant is the same thing as refractory, is the same thing as intractable. But I think those latter words are a little misleading because just because I'm drug resistant doesn't mean that I'm resistant to everything, right? We have all this other stuff.
So pop quiz.
Yeah, here's the audience participation part. I warned you, for all those introverts like me. All right, so we're going to raise our hands if we think that this patient may be a surgical candidate. No one's holding you to this, okay? All right, a 14-year-old girl with a prior right temporal lobectomy, for multiple daily seizures, so she was having multiple daily seizures, now with worsening depression and recurrent seizures localized to the other side. So now we're seeing seizures that we think coming from the left. Show of hands, do we think that this patient at least deserves a workup for epilepsy surgery? Yeah, I think so too.
What about a 15? What about a 15-year-old young woman with multiple daily seizures with a localized focal cortical dysplasia in the language and motor area? Would this be a surgical candidate?
Super close to language and motor, are you sure? It should at least look, right?
Yeah.
I like it. How about a 5-year-old boy with autism, intellectual disability, multiple daily seizures, epileptic spasms, atonic seizures from multiple and bilateral sources? What do we think? Less hands, but let's work them up and see what happens.
And then what about an 18-year-old young woman with daily seizures? Imaging shows a lesion in the right temporal lobe, and the EEG shows epilepsy on that right temporal lobe.
Yeah, that's our
So
slam dunk.
that's
right?
a gimme. Yeah.
Yeah.
So unfortunately, most of our patients aren't slam dunks, and they're more challenging. And so that's why we're presenting these other cases, because sometimes people may not think that someone is a surgical candidate, but if you look. But if you look hard enough, potentially there are other options. And as technologies have advanced, that's opened up other opportunities to be able to help our patients. So we'll start with the first patient that we described. So this young lady had a 2-year history of seizures. She was having about 2 to 3 seizures per day, and she had already gone through 4 seizure medications, and she was continuing to have significant seizures. So she went to surgery and had SEEG placed, and I'll talk a little bit about what that means. And we were able to capture seizures, and the majority of the seizures that we captured while the electrodes were in place were in the right temporal lobe. But when we're monitoring for seizures, we sometimes will decrease the seizure medications to help elicit seizures. And when that happens, then sometimes other seizures start to pop up, or other activity can start to pop up. And that's exactly what we saw here in this patient. So after 3 days of being off of seizure medications with electrodes in place, we found that she started having some activity on the other side. But those seem to be controlled with medication. So again, initially when we monitor, we place the SEEG electrode. So just so you guys get an idea what that means, these are the electrodes that we use. They're small, less than 0.8 millimeter electrodes, and they're placed stereotactically. So at our facility we use the ROSA robot, which is a navigation system. So we do lots of planning in advance. So again, we have a conference where we discuss the patients, and based on where we think the seizure are coming from, that determines where we place the electrodes. And so we plan all that on the computer. And then the day of the surgery, we use the robot to help us find the entry point where we're going to place the electrode, and to help calculate the distance, how deep we place that electrode. So that's an example of the robot there with the drill as we're making the small opening for the electrode itself. The setup is fairly simple. There's just a driver basically to get this bolt in place, and the bolt is what secures the electrode in place, so that while we're monitoring, the electrodes don't move. And there's a little cap that helps secure that. And so this is an X-ray just right after the surgery, showing an example of electrodes placed, bilaterally, again based on the hypothesis that we have for a particular patient. So again, in the patients that we described, the seizures, all primarily her typical seizures, were all captured from that right temporal lobe. So once we had all the information, we took the electrodes out, and then we met together as a team, and we went over all the potential options. So one option was to do a temporal lobectomy, so to resect that temporal lobe that seemed to be the most active in causing her primary seizers. However, we knew that she had some activity on the other side, so then the other option would be to place an RNS, and I'll talk a little bit more about what that is, responsive neurostimulator, and you can place that bilaterally, so you can cover both areas. And then the other option was to do a combination of both. So after extensive discussion with the family decided to have the temporal lobectomy done first, since that seemed where the seizure were primarily coming from, and it seemed like the other seizures were controlled with medication. So we did that. She had a successful temporal lobectomy, and she did well. And all the seizures that she was having before, they were all gone, and she was great. However, over time, not unexpectedly, because the medications don't always work forever, over time, some new types of seizures started to come about. And when she had an EEG done, it looked like it was coming from that left temporal side, which we had already seen before. And so, we can't do a bilateral temporal lobectomy. We can't take out both temporal lobes, so that's not an option. But we do have the option of placing what's called an RNS. And so this is an X-ray showing the RNS in place for this particular patient. And so the RNS, or responsive neurostimulator, or NeuroPace, which is the company that makes it, is a device. It's essentially like a little computer that is able to capture the electrical activity wherever the electrodes are placed. And then over time, the epileptologist is able to adjust the device so that it recognizes what a seizure looks like and then can respond and send a signal to help stop that seizure. This device has been FDA approved for almost 10 years now, but it's approved in adults with partial onset seizures who failed 2 or more seizure medications. With that being said, we have implanted these devices in children, and there's an ongoing trial, and that's what I was talking about before, the response trial, to show the efficacy and safety in pediatric patients as well. So again, these are just some pictures kind of showing what the device looks like. The generator itself, the computer, gets implanted into the skull, so this is an illustration here kind of showing what the steps are for the procedure. There showing, this is an example of someone who has seizures coming from the temporal lobe, and so we place an electrode starting from the back and kind of goes along what's called the hippocampus. And so the electrode is placed, and then the generator area is planned, typically here in the parietal area. We mark an incision. And then we remove the bone in that particular area where we place the tray that helps secure the device in place. We connect the device, and then while we're still in surgery, then Dr. Phillips and the epilepsy team come in, and then we look at the electrical activity and make sure that we're seeing what we need to see. And so, again, RNS is a closed-loop system which delivers stimulation to the seizure onset zone. So first we have to know where the seizures are coming from, and we want to send a stimulation to that particular area. So again, in our patient, we already had that information because we had placed the SEEG electrodes before. Now, this is different than other neuromodulation devices, such as the DBS or the VNS. Those devices are open loop, so essentially they're just sending signals throughout the day with the idea that over time it'll reduce the seizure probability. So it's not directed at a specific seizure per se, but it's directed, it's helping to decrease seizure activity, but not responding to a specific seizure. One caveat to that is the VNS does detect the heart rate of patients, and so if we know that for 82% of patients who have epilepsy, the heart rate goes up right before a seizure happens, and so it'll send an extra signal at that time. So it's not detecting the seizure per se, but it's detecting that change in heart rate. So it does have a response feature to it. And then, as I mentioned before, the RNS is not FDA approved in pediatrics, but there is a multi-center clinical trial going on, which is called the response trial, where we're looking at the safety and efficacy for this device. Most of the research that's been done so far has been in adults, and then we can see that with these different papers, at 1 to 2 years, we see about a 50% reduction in seizure activity. At 3 to 6 years, we see about 2/3 reduction, and at 9 years, we've seen up to 75% reduction. So again, not a curative procedure, but it can definitely make a significant impact in somebody's quality of life. Overall, the RNS is well tolerated. Like with any surgery, there are risks associated with it. You can have risk of infection, small risk of hemorrhage, or the lead could get damaged, but again, the risks are fairly low. There is some early data looking at RNS in pediatrics. So this is a paper out of Mount Sinai in New York, and so they looked at their initial cohort of 27 patients. And the point of the slide is just to show that they were seeing similar results as with the adults. They saw approximately that half their patients were getting a 75 to 100% reduction in their seizure frequency. And then the paper did discuss that there are some issues sometimes with getting insurance to cover it, and part of that is because it's not FDA approved yet. So once that process happens, then that'll make that a little bit easier. So what about our particular patient? So again, she had a right temporal lobectomy. Then we placed the RNS on the left side, where we saw that initial activity on the SEEG, and what we've seen is that over the course of the year, she had gone about 6 months seizure-free. There was one day where she was playing sports and it was really hot, so her seizure threshold lowered a little bit, so she had a cluster of seizures. But then after that, her seizures have been well controlled. So again, if you remember from the beginning, she was having multiple daily seizures. When the seizures recurred and she had the new types of seizures, she was having them maybe a couple times a month. and then now she's gone to very rare seizures. So it's made a tremendous impact in her life. And the other point that I wanted to make with this slide is that with the RNS, when you implant it, you don't get immediate decrease in seizures because the device needs to be trained to know what the seizure looks like. So that process takes months. So we implanted the device, and for months, we don't necessarily even turn it on. It's just detecting the activity. And so once the epilepsy team captures enough information, then it's able to train the device and say, okay, this is what a seizure looks like. This is what you respond to. And so that process does take some time, but it can be very successful.
Before you go on, so first of all of you got that right. Good job. You mentioned we can't operate on both temporal lobes, and I just wanted to flesh that out a bit. So classically, when we talk about resective epilepsy surgery, we're talking about a single focus on a single side. The brain is very good at compensating for lost material, especially when we're young, this so-called neuroplasticity. A lot of that compensation is from mirrored structures on the other side. And so we can't remove both sides, kind of the same tissue on both sides, because then we'll lose the ability to compensate for whatever we're taking away on the one side. And so for a long time, patients with bitemporal disease, seizures coming from both temporal lobes, were not surgical candidates. But now, either through a strategy of resection on the worst side with a neurostimulator on the other, or a neurostimulator on both, those patients have, a lot of them have done very well. So this one included.
Perfect, thank you. So now we'll move on to the second patient that we discussed, our 15-year-old young woman with multiple daily seizures that were localized to a focal cortical dysplasia right next to the motor and language area. So again, the concern there is she was highly functional, a straight A student, did very well, and so we wanted to minimize any potential for neurologic deficit. And so she was having she had about a 1-year history of seizures. She was having about 1 to 3 seizures per day, so again, daily seizures. And typically during her seizures, her head and eyes would deviate, and occasionally she would have generalization of her seizures. And she, again, had also failed 2 medications. So she had her epilepsy surgery workup done, which included an MRI. And fortunately, in her case, we were able to find the lesion. Many times we get MRIs and they don't necessarily show a structural lesion, so that can make it very challenging to determine if somebody's a surgical candidate. But when we see a lesion, it makes our job a little bit easier. And so here we can see this is what's called a coronal MRI, T1 weighted. We're essentially looking straight on, and it's a slice this way. And so this is her right side, that's her left side. And then you can see here in this area, you can see how that tissue is a little bit thicker compared to the other side. And so that's the area where the focal cortical dysplasia is. We can see here this is the same image, but just a different sequence. And then here you can actually see this kind of classic tail that goes along down towards the ventricle that is very typical in these focal cortical dysplasias. Now this is similar images, but just in different orientation. So for this image, the patient is lying down, facing up. So her eyes are up here, the back of the head is here. Again, this is the right side, that's the left side. And again, you can see in that area there the changes where the focal cortical dysplasia is. And the reason why I wanted to show that image is because as part of the workup, we also got what's called a functional brain MRI, which helps us to determine where the language and motors areas are. And so this is some images of her functional MRI. And so you can see that they do different paradigms during the testing. So while the patient is getting an MRI, they have them do different activities, move their hands, move their legs, say words, repeat, say sentences. And so you can see here, these are different tasks that they're asked to do. So this is verb generation, that's saying sentences on that side. And then you can see the idea here is that these brighter areas here, brighter area there, is what corresponds to the activity when somebody's performing the task, and then that helps to localize that function. And so we can see that that's in a very similar area to where the focal cortical dysplasia was. This is an example of the motor tasks that were done, and again, the motor area seems to be in that similar area. So in that case, again, we presented during a conference, discussed it with the whole team, and the idea was to perform a craniotomy and place grids and strips, so electrodes directly on the brain, so it can map out those functional areas. So we can map out where the seizures are coming from and how they're related to the functional areas of motor and language, and to determine if there's a possibility of taking it out safely. And again, if we find that it's not, that those areas are interrelated, then there's always the option of something like an RNS that can then respond and treat the seizures. In her case, we used so these are what the grids look like. So each contact, so we record activity at each of those contacts. And so this is an example of what's called a mini grid or high density grid. So she was part of a study looking at the use of using higher density grids, so the contacts are closer together. Normally contacts are about 1 centimeter apart. These are only about 3 millimeters apart, so it's higher density, so you get a lot more information. Sometimes it's a lot more work to interpret the data, so that's why we don't have the electrodes right next to each other, because but the idea is that if you have higher density, you have better spatial resolution, then you're able to differentiate different areas a little bit better. So in her particular case, because we were in that motor area and language area, we wanted to get as much precision as possible. And so once the electrodes were in place and we captured her seizures, then the epilepsy team then did what's called language and motor mapping, which essentially means that they go around the areas based on the imaging studies that we have in normal anatomy. We go and stimulate at each contact, so and then we see what functions are affected during that stimulation. And so as you can see here, the areas that are circled in blue, so those are all the grids and strips that we had in place. And so the areas in blue are the areas where we found the motor function during the stimulation. And then the areas in orange are the areas where we found the language function. And then the area with the bright orange and the green there, that's where the seizures were starting. So when she had a seizure, that's where we captured it. So you can see it was right next to language and right next to motor. So just adjacent, and then the activity kind of spread out. But then we could see that language and motor, it was safe above that. So then we knew that we could take out more tissue there without causing any neurologic deficits. So this is an intraoperative picture. It's a picture during the surgery showing the actual grids in place. So again, there's the high density grid. And then we have the other grids all around. And then we can see the yellow area is where the seizures were starting. The purple area is where the language function is. And then the blue dots there is where the motor function is. So you can see they're very close together, but separate enough. And again, each of these contacts are only 3 millimeters apart. So we're talking about less than a centimeter distance there. But once we were able to isolate that area, then we exposed that structure, and then we were able to resect that focal cortical dysplasia. And then we knew that it was safe to go further that way, because once we're there, we can also, there's a different texture to the lesion, and so we can kind of follow that texture and carefully separate it from the surrounding tissue. And so we knew that we could follow it in the other direction without affecting language and motor area. So this is what it looked like after we were done. And then that's the example of the focal cortical dysplasia that we then sent to pathology. And that surgery was over 3 years now, and I'm happy to say that she's been 3 years seizure-free, and she's a successful college student. So she's done tremendously well.
So congrats for all of you who got that one right as well. It's such a great example of a case that, sort of before any of this was done, it would have been too close to motor, too close to language, not a candidate. But through careful mapping, in this case with those microscopic little electrodes, we were able to differentiate the two. And you saw the surgery is small, right? The area is actually quite small, and so able to remove what we needed to, leave what we needed to, and the patient's doing very well. Should have given you a trigger warning about brain pictures. I'm sorry.
How have her meds been changed since she had such successful surgery too? I mean, that's a huge benefit too.
Yeah, no, absolutely. Thanks for bringing that up. So she's actually been weaned off seizure medications, and so yeah. So and that's a good point to bring up, is that many times when we talk about surgery, we're not saying that we do surgery and then that's going to be the end all cure all. And many times we go into it knowing that we're going to continue the seizure medications for at least a year or two, and then depending on what the EEG looks like and depending on the conversation with the epileptologist, then we start to consider potentially lowering the medications, or maybe the patients are having side effects from certain medications, maybe trying to reduce some of those medications. But we're not always successful in weaning all the medications, but in certain cases we are.
Yeah, seizure-free is best, and so whatever combination gets us there.
Yeah.
But if surgery truly is curative or near curative, and we can lighten or get off the seizure medications, it has a cognitive benefit. And my unscientific way of thinking about this is, when I'm having seizures, my brain has some illness to it. It benefits from the medication. When the seizure network is no longer there, that brain is similar to a neurotypical brain like yours or mine. If we took seizure medication, we would not feel well. And so the patient is a different patient after surgery and then benefits from coming off eventually medication if possible.
Okay, then we'll move on to our next patient that we talked about earlier. This is our 5-year-old a little boy with autism, intellectual disability, who presented with multiple daily seizures, spasms, and atonic seizures coming from multiple areas on both sides. So again, as we talked about before, there's no specific focus that we can target, but for these patients, particularly with atonic seizures or drop attacks, performing what's called a corpus callosotomy can significantly help. And so classically, corpus callosotomy was done with a craniotomy, so we make an incision, open up the bone, and then the corpus callosum is the structure right here, right? It's a big highway connecting the two hemispheres, and the idea is that we go in between the two hemispheres, and then we see this structure here, and then we resect it, and we disconnect it. And so here you can see kind of the opening in the bone as we go in. And this is the image after the surgery, showing that you no longer see that corpus callosum structure after the disconnection. So that was a classic procedure, and it works very well. But again, surgery is scary for anyone, and so many times patients are not, or families aren't open to doing a craniotomy for this type of procedure. And so fortunately, as technology has improved over time, and we've come up with other options. So now we're able to do the same procedure, disconnect the corpus callosum, but we can do it using a laser. And so this is an example of a laser ablation system. And so essentially, similar to with the SEEG, there's a bolt that's secured to the skull. We place the probe down to where the target is after we've determined where the seizure focus is or what structure we need to ablate. We place the probe in that area, and then we heat the tissue to essentially destroy it without having to resect it. So instead of having to make a big incision, a big opening in the bone, we're working through 3-4 millimeter incisions, a small opening in the bone, and just placing a probe down to the target. Once a probe is in the target, the patient is in MRI, and I'll show some video of that as well. And we can actually see, so this is actually the patient inside of the MRI here. And so we can actually see the tissue as it's heating up. So again, we do a lot of planning in advance. The corpus callosum, you can see, is a curved structure. The laser probes that we use are straight devices. So in order to be able to fully ablate the corpus callosum, you have to take several trajectories. So sometimes it takes 3, sometimes 4 trajectories, but we want to be able to ablate the entire structure. So it's a little bit probably hard to see in the back, but you can see one trajectory going this direction, one trajectory going here, and then one trajectory going here. On the right side there, you can see that's the preoperative plan, a 3D image showing the 3 trajectories for where the electrodes are going to go. This is the patient in surgery, and then you can see the bolts here in place that are placed at the planned entry point in the appropriate trajectory. And so this is done in the operating room, again using the ROSA, the robotic system that we have that you'll see outside. And then once those are in place, then I place a probe all the way down to target. We get a picture to make sure that everything's accurate. And then in surgery, we can see the tissue actually heating up. So these are the images. So as the tissue is getting heated up, we're taking MRI images throughout the course of the procedure. And so again, you can see here is the laser probe. You see this is the tip of the probe, and then you see the yellow structure getting larger. That's the area that's getting heated. And so there's a yellow image, and then shortly you'll see a blue image. And so initially the yellow image is showing what area is getting heated, and then the blue image is showing once that tissue is completely destroyed, and it's essentially as if we cut it or resected it. So we're showing, again, because there are different trajectories, we did the long trajectory first. Now we're doing the front part of the corpus callosum, which is called the rostrum. And then we take the third trajectory to get the back part of the corpus callosum there, heating up that structure, and then completing the corpus callosotomy. So here in the video, it looks like it just takes a couple minutes. This is it actually takes most of the morning. There's a lot of steps because we have to place the bolts in the operating room. Then we go down to MRI, and then in MRI, it obviously takes time to heat the tissue. But This case, for example, was like 33 minutes of heating time. You can see on the bottom right corner. You have to heat up the tissue, and then you have to move the probe. There are 3 different probes. There are lots of different steps, so it takes several hours. But again, it's minimally invasive, small incisions, and typically patients are able to go home sooner than if they would have a typical craniotomy. So here you can see the image at the end with the tissue ablated. And then, so you can see there's the corpus callosum. And then we took an MRI at the end of the procedure. And then we can see the area around that's kind of bright, showing the full area that was ablated. So again, this is essentially like doing the open callosotomy, but just doing it through three small incisions. So this is a patient of ours that we just recently did over this past year. And so it's still less than a year follow-up, but we've already seen about a 90% reduction in seizures, which is amazing. But not only that, the family has already started to see improvements in different cognitive domains. So that he's a lot more alert, he's more active, he's starting to say words, which he wasn't saying before, and this is over a short period of time. So as Dr. Phillips mentioned earlier, there are these critical periods of development, and I think if we can get the seizures under control during those times, it's going to give patients the best chance of cognitive development over time.
Yeah, I'm so excited for him. When the brain's seizing, that often is not doing anything else useful. And so whenever families rightly and correctly ask what are the side effects for surgery, we always try to contextualize that against what are the side effects of not doing so. And I think for some of these big developmental epilepsies, the side effects of not intervening, or what we call the opportunity cost of not intervening, is pretty high. I would also, just for any of the kids in the audience, whenever your parents start talking about you're playing too many video games, just remember you're training to be a neurosurgeon, right?
All right.
So congratulations on those who got that one right.
Yep. And now we'll talk about our patient, which was the slam dunk, as Dr.
Yes.
Phillips said. So this is our 18-year-old young lady who's having daily seizures. Again, she had an MRI showing the lesion in the right temporal lobe, and the VTM showed that the seizures were coming from the area. However, we do additional studies like a PET scan, a SPECT scan, and things like that. And so when all of those studies are concordant, sometimes it can go, meaning that they all match up, sometimes we can go straight to surgery and remove that particular area. But when all the studies don't completely line up, then sometimes we still need to do invasive monitoring like we did in the first case to make sure that it's truly coming from that temporal lobe. Because we do know that seizures can spread very quickly. So when you do an EEG, you're relying on the activity to spread out to the scalp. But the information could travel in different directions before it gets up there. And so because there are connections between the two temporal lobes, it may go to the other temporal lobe and then go to the scalp. So you sometimes may be tricked and think that it's coming from the other side. So in this particular area, patient, because we didn't have all of the studies lining up, we did place electrodes on both sides, and sure enough, the seizures all came from the right temporal lobe. So again, this is the MRI that I described earlier. You can see how this area is a little bit brighter compared to this side, similarly on there. And then this is the MRI after the procedure, where we've done a temporal lobectomy and removed that tissue that was causing the seizure. So again, this was a quintessential resective case where we knew that there was a lesion. The electrical activity came from that particular area, and we had a great outcome. This patient is now 5 years out. I can't believe time flies so quickly, but she's already graduated from college and is now working on the community and has done tremendously well. So we can see that this is again a great example of a classic temporal lobectomy, temporal lobe epilepsy treated with a resection and with great outcome. But hopefully you can see with the other cases that we talked about earlier that there are other definitions of success, and you can see how you can significantly improve a patient's quality of lives, even if the lesions are bilateral, even if they're close to very delicate structures. And so the definition of who is a surgical candidate, I think, is very, very broad.
Home stretch, guys. And yeah, I called that one a slam dunk, and I don't mean to be glib about it at all. I mean, I think it takes tremendous partnership with our patients for for you guys to extend trust to us to do this. We sort of conceptualize it in that way only because there are so many people walking around with this lesion who are having seizures who could not be having seizures. And this is something that is done very routinely now. And 5 years off medication is equivalent to remission for epilepsy. So that seizure risk drops to that of the neurotypical population, which is less than 1% per year. So who is a surgical candidate? It's a tough question. An easier one is surgery a potential option? And that's what we want to get people thinking about. I am not seizure-free despite trying 2 appropriately chosen medications. Can I ask the question? The most important box on this slide then is this one, is the referral one. How do you get from here to here? And so that is maybe a primary care provider, maybe that's your general neurologist, maybe that is someone here, right, who recognizes that we're not seizure-free. Maybe that's your epileptologist who, goes back in her head and says, oh, things have changed and now we are a candidate for something, right? But that step is the most important one. We do the pre-surgical evaluation, which is beyond the scope of what we're talking about. It's a ton of stuff, but I've listed a few things here which you can not read. The long-term EEG, the MRI, the neuropsych testing, the PET, the SPECT, all of the stuff that we typically do to triangulate where the seizures are coming from and where the important stuff around it live. And then we have a discussion, right? It is, we bring the science and then we have a discussion with you, what's best for you and your family, and come up with a solution. This is an algorithm that you can't read, but it's a more modern algorithm. You see lots of branching points as far as what may be available, and I think that's 2018, that's outdated now, but it's a good example. Not everyone's path is a straight line though, okay? There's life that happens in between. There's good things like I have a few years of seizure freedom, and there's life things like I'm busy with other stuff. I have other kids. I have life. It's our job as much as we can to straighten that knot out a little bit though, through working together, because we know, paper over there, that early surgery has better outcomes, developmentally and seizure-free wise. This might be the biggest thing on this slide though, is this has to be a continued conversation with your epileptologist. Again, there's this thing called status quo bias. I have known you for 4 or 5 years. We did this thing 4 years ago. We determined you're not a surgical candidate. Meanwhile, science happens, but we're so used to doing the same dance kind of thing. So we need to both break out of status quo bias. Hey, doc, like you keep talking about all this stuff. And like, oh yeah. So I mean, like, a lot of we are trying to do this in a very formal way by going back in our patient populations and building natural language process algorithms and going through the chart and everything else and looking for these, kind of missed opportunity patients and signs of emerging epilepsy and everything else. But it all starts with the conversation and the teamwork. One point about time, something that might be curative early in life may be palliative later in life, because as the seizure network matures and evolves, it gets better at doing what it's doing. So example, I have single temporal lobe epilepsy that may become both temporal lobes if it goes on long enough. And so the idea is if we have an opportunity with the same procedure to be curative and not palliative, we want to take it. So again, that's that early intervention. Long. This was a position paper recently put out, senior authored by J. Helen Cross, who is universe famous for epilepsy. And the gist of this is that for lesional epilepsy, this is where we're going to thinking. If I have something on the EEG and I have a seizure from it, even if we're not yet intractable, more and more we're thinking about doing epilepsy surgery earlier because of the benefits, because of the safety profile, And so this last bit here is epilepsy surgery is an early treatment option rather than a last resort, taking us back to our first slide.
So in conclusion, hopefully we've shown that there are different surgical techniques that can be employed. They can be done safely and they can work well.
Rapid and significant advances have broadened the spectrum of patients who may benefit from epilepsy surgery. So these things are getting more precise, they're getting smarter, they're getting better.
And then again, as we talked about, we can talk about surgery as a curative procedure or as a palliative procedure, but in both cases they can significantly improve patient outcomes.
Successful surgical outcomes may go beyond just seizure count, right? So cognition, development, what we can do in life, all important factors when making this decision.
And as we've mentioned, earlier surgery leads to better outcomes. So the earlier we can diagnose, the earlier you get referred to an epilepsy center that has these options, the better you will do.
So who is a surgical candidate? It depends. It's dependent upon our process, but it's predicated on asking that first question: could surgery help? Without that first question, we never do the rest.
So as a surgeon, obviously I have these conversations with patients and families all the time, and one of the biggest and most important questions is what are the risks of surgery? And so we know that surgery does have risks. Sometimes complications do occur. We try to minimize those risks as much as possible, but we also know that we see the benefits. We see the other side of that when patients have had the surgery, and we see the potential outcomes. And so when we balance the risk and benefits, we see that those benefits definitely outweigh the risks. And we also know that although surgery may have risks, not doing surgeries may have even greater risks.
So, in summary, if seizures are not controlled, patients should be referred to a level 4 epilepsy center to discuss potential surgical treatments.
Yeah, and so we talked a little bit. I wanted to include a little bit of different techniques that we have. We talked about our ROSA robot that we use for placing electrodes and placing these laser probes. We talked a little bit about the laser ablation technique. We talked a little bit about RNS. But there's lots of other things that we didn't even get a chance to talk about today. There's the VNS, there's the DBS, and there's newer technologies that are always coming out. So again, as Dr. Phillips mentioned earlier, this should be an ongoing conversation. If seizures are continuing, this is a conversation that needs to happen because there may be new strategies that maybe weren't there 3, 5, 10 years ago.
So I want to take just 10 seconds to call out everyone who makes all of this possible. We have representatives from our neurodiagnostic lab, our nursing team, our industry partners, our families. Thank you so much. And we'll take a few questions if you guys want to sit here for a minute.
So your examples were primarily patients that have daily seizures. How about those that don't have seizures?
So I think that is the component of the discussion where we talk about impact, because even if you're having one seizure a month, but every time you have a seizure it's 20 minutes long and it's convulsive and it's dangerous, right? Or even if you're having one seizure a month but it keeps you from driving and working, those are all very impactful still. And so that's the calculus we make when we're doing that risk-benefit analysis. And I think with the risk and the amount and the level of invasiveness going down on some of these things, that talk becomes a little bit different. And so that's why we want to make sure everyone's aware of all of this, because it might all of a sudden make sense because of the impact the seizures are still having. Yeah. I'm going to see if this works. What? No worries. Hi, help.
Does the RNS work for focal aware seizures in adults?
Yes. I actually was testing it once. And whether we have focal aware or focal impaired cognition, it just depends on real estate, like where the seizures are coming from. So it should work for both, as long as we can do the same.
Okay, interesting. Well, I appreciate y'all. You really opened up this for me. What's possible?
Okay.
Siri now is not.
All right, thank you guys for listening.